Hi, this is Professor O'Connor, and this is part 3 of your pre-class assignment, and this will be talking about tonsillitis. Tonsillitis is caused by a virus or a bacteria, and that causes the tonsils to become inflamed as a result of the infection, and it is known as hypertrophy of the palatine tonsils. Tonsillitis is diagnosed by visualization of the palatine tonsils, which will appear large and inflamed, as is demonstrated in this picture from your textbook, from the government, and a throat culture. And adenoids would need radiologic studies. Assessment findings would show frequent throat infections, breathing and swallowing difficulties, enlarged cervical lymph nodes. These children would tend to be mouth breathers and have dry, irritated mucous membranes. If they have adenoiditis, they would have nasal stuffiness, nasal discharge, postnasal drip, coughing, and excessive throat clearing. This is a photo from your textbook showing enlarged and inflamed tonsils with white exudate, and it's very typical of tonsillitis. Medical treatment tends to be treating the symptoms. So we would administer acetaminophen for pain and fever. Antibiotics would be administered if it's a bacterial infection. And we can offer cool, non-acid soft foods, ice chips, and frozen juice pops. Surgical treatment would be a tonsillectomy if they've had recurrent infections, and that's defined as 3 infections per year for 3 successive years. Or they could have chronic tonsillitis, obstructive sleep apnea, malformations that cause sleep disorders, and facial growth abnormality. If a child is under 3 years of age, they try to postpone the tonsillectomy for as long as possible because they have a much greater chance of the tonsils growing back and hypertrophying. So for your nursing assessment, you're going to assess for fever currently or by history, assess for a history of pharyngitis, sore throats, or tonsillitis, and for hoarseness or muffled voice. You will want to inspect the pharynx for redness or enlargement of the tonsils and look for any difficulty of breathing or swallowing. You'll want to assess the tonsils that might be so swollen that they actually touch at the midline, and they are called kissing tonsils. If that's the case, the airway actually may become obstructed, inflamed. The adenoids can cause obstructed posterior nares. They will be mouth breathers or snorers, and you can palpate the cervical nodes for tenderness and enlargement, and you would want to do a rapid test or a throat culture for looking for positive group A strep. Nursing management, if the child is having surgery in the preoperative phase, we need to make sure that the child has no signs and symptoms of tonsillitis. It's a very bloody procedure, and if they have an infection present, then that can lead to bacteremia and sepsis. We also want to make sure that the clotting studies are normal, such as PT, PTT, and platelets. Because it's a bloody procedure, we want clotting to occur at the correct time. For postoperative, the main thing that we're going to be looking for is promoting airway clearance. And to do that, the child needs to be placed side-lying or prone until they're fully awake. Once they are fully awake, they can sit up and have the head of the bed elevated. You'll only suction if it's absolutely necessary, because anything placed inside the mouth could disrupt the scabs that have formed from the cauterization. There may be dried blood on the teeth and nares and in the emesis, and if that occurs, it can be frightening for the parents. However, it is not a medical emergency. One of our goals is to maintain fluid volume, and so to do that, we're going to encourage fluid intake, offer cool or cold, clear liquids, no milk products until 48 hours after surgery. We're going to also not offer citrus, brown, or red fluids, because when the child goes home, the parents might confuse that with bleeding. We also need to calculate the 24-hour fluid volume so that we know when the child has reached 1/3 to 1/2 of their daily fluid requirement, and in order to be discharged, they have to have reached between 1/3 and 1/2 of that fluid requirement. We want to monitor for postoperative bleeding. Hemorrhage can occur immediately post-op and in up to 10 days after the surgery. We want to inspect the throat for bleeding, but place nothing in the throat. Mucus-tinged with blood can be expected, and that's not a sign of bleeding. Fresh blood in the secretions does indicate bleeding, and continuous swallowing or frequent clearing of the throat can indicate bleeding and should be followed up on. Other signs of bleeding would be tachycardia, pallor, restlessness, and emesis of bright red blood. We also want to relieve pain, so we're going to administer acetaminophen 10 to 15 milligrams per kilogram per dose every 6 hours around the clock. Tylenol with codeine is no longer recommended, so it is not prescribed. We may use an ice collar, and we can use ice chips or sips of water. We want to also prevent trauma to the surgical site, so to do that, we discourage the child from coughing, clearing their throat, blowing their nose, or using straws. Absolutely no straws. For home care, we need to teach the parents to report any sign of bleeding to the healthcare practitioner. The child needs to drink plenty of cool fluids, no milk products until after 48 hours post-op. Acetaminophen every 6 hours around the clock should be continued, and it is possible for the child to use an ice collar around their neck if they find that that is comforting. No suctioning of the back of the throat. The child can advance to a diet that's soft and with bland foods, and we want to discourage coughing, clearing the throat, and blowing the nose. This is the end of part 3. Please go to part 4, and thank you very much for your attention.